Karen, if anybody shouldn't have trouble, it's you.
You can go now.
Okay. Okay, so welcome everybody. We are going to be speaking about the holy grail that people have said of venous disease, which is somehow getting a functioning valve in the deep venous system. And just for you all know, but for our readers and our listeners, all of you have been intimately involved with venous disease and certainly deep venous disease for a long time. And we kind of want to get some ideas regarding the updates. Some of you have been involved with industry, and some of you have been involved as physicians in trying to get somehow a functioning valve into the venous system. So my first question to all of you is, why do we need this nowadays? Can't we take care of like 98% of the vein problems with what we have now? And we really need a functioning valve based on kind of the knowledge we have regarding the pathophysiology of most venous disease in 2017. So onto that for a moment, and I'll go to one of the fastest thinking individuals, which is Tom O'Donnell. So Tom, give me like a little gestalt, and obviously it's a leading question here, but really, why do we need to pursue this in 2000?
Well, I think you can look at it historically, and I see Bob Kistner's image, but not on live. And if you go back and look at the way we approach people with, as we all did with advanced chronic venous insufficiency, C6, we attacked the superficial system. And through various superficial operations, ligation stripping and SEPs, etc., we had a certain group of patients that were refractory to this treatment, and those are the patients with deep venous disease. And if you look, just using the ESCAR trial as an example of what proportion of patients have deep venous insufficiency, 25% had mixed with segmental, and 13% had mixed with total. In other words, total deep venous involvement. And these are the patients that didn't respond to treating the superficial venous system alone. So what we're talking about is a percentage of patients that won't respond to the traditional reduction of superficial venous hypertension. So we need to correct the deep venous disease, which is, and I want to point this out because it's going to affect what choice you use as an operation. Post-thrombotic, which is notoriously the most resistant to treatment, and primary valvular incompetence.
Right, and so Bob Kistner, so let's follow up on that. If when you pioneered, valvoplasty and everything, if you knew then what you know now regarding the significant percentage of people who actually have secondary disease due to previous, post-thrombotic, like Tom said. What, just in looking back, and I mean, you did pioneering work, but do you think there were a certain percentage of those patients that you were doing valvoplasties or considering valve transplants that actually had more proximal disease, but we didn't have anything in those days to help them with? So we went down and took care of their veins from the inguinal ligament down. Bob?
Well, Steve, I think his mic is muted. Maybe you cannot hear. I see the image, his mic is muted.
You're exactly right, Nikos.
Yeah. All right. So let's go to Fedor. Talk to me about the question I answered Bob. You don't have to ask. You don't have to answer. Don't have to answer for him. But think about it. Do we feel that there probably was a certain percentage, more than we would appreciate back in the late 70s or early 80s, that really had disease above the inguinal ligament that we either didn't appreciate or we said we can't do anything about? So, let's deal with the problem from the groin down.
Steve, I think you're right. In the 70s and 80s, we grossly underestimated the influence of iliac obstruction and probably didn't know the incidence, prevalence of that condition. However, if you look at the pathology, as Tom and Donald pointed out, it's not always obstruction, and it's either combination of obstruction and reflux or just reflux alone, which is present in substantial proportion of the population, especially in severe disease. So even knowing then what I know now, I probably will go the same route. Less prevalent, yes. Probably some of the problems can be successfully treated by treating iliac obstruction. But will these pathologies still remain and cause problems? I think the answer is yes.
All right, so Nikos, let me ask you, if you had to either fix somebody's obstruction or fix somebody's insufficiency from a hemodynamic viewpoint, which one do you think you get your biggest bang for your buck?
Well, it will be hard either way for the femoral veins, reflux or obstruction stuff. But eventually, even if you are to treat obstruction, you're gonna have a reflux, right? So eventually, you have to fix the reflux in that segment. I want to add what Tom said earlier, just to give you some more data, without mentioning any of my papers, Steve. Okay. So
you can mention 5 of them during this 1 hour.
So if you look, some of the data and systematic review done on this, about 17 to 60% of people with ulceration have post-thrombotic changes. The mean value is about 33%. So 1 every 3 people with an ulcer is going to have some obvious post-thrombotic disease. Therefore, most of which is actually on the femoral veins. Therefore, there is an enormous need to address this issue. It has not been addressed, although it's been known, because we don't have the means currently. But if we develop them, I think it will be of great service to the community.
All right, good. So,
but to answer Steve, to answer your question directly, do you do treat obstruction or reflux? Raju has done a study just correcting reflux and has shown clearly that even in the, correcting obstruction, even in the face of reflux, this helps remedy the situation with ulcer healing, at least in the patient's small number that he followed up.
Right. But Tom, this is true for the iliac veins, not the femoral segment.
Oh, I totally agree.
Yeah.
There are some interventional radiologists out there dilating those or doing something to them, but the principal problem there, I totally agree with it, Nikos, is reflux.
Right. Now, Franz, in your side of the Atlantic, what is the current thinking regarding the search for a functioning deep venous valve?
I think that there's great interest also in Europe in this pathology. Not only Case Wittens is working on this for years. Myself is our own group is looking for it as well. We started in the 80s and 90s of the last century. And the whole thing is that we have to prove in Europe so many times that it is kind of evidence, etc. As soon as you go in this direction of evidence-based, I think it's still too early. And we have enough proof from other studies that going into the direction of flow regulation is truly a beneficial direction and will benefit the patient ultimately for treating their deep venous insufficiency. So also the healthcare insurance companies, they are following us closely, but they are willing to accept our research.
Okay.
Hi guys, sorry.
Okay. Bob is back. All right. So Bob, were you hearing any of our conversation? Bob?
Yes,
No,
I'm here.
Bob is not back anymore.
No, he's there.
Oh,
He's there.
Bob Kistner. Were you hearing any of
Yeah.
our conversation?
Hear any of your conversation up till now?
Okay, good. So good. So now you will
After the origin, you were just trying to look around.
So he's double blinded.
good, perfect. So Bob, you will not be colored by anybody else's answers. So my question to you, Bob, is why do we need to correct reflux when we have so many other good things nowadays to treat venous disease? And the other corollary to that question was, which I was asking you when you couldn't hear it, can you talk to us a little bit about, I mean, you were extremely pioneering regarding valvuloplasty. What are your thoughts in retrospect now? What patients that you perhaps did valvuloplasty actually had disease above the inguinal ligament that we really didn't appreciate at the time? And, do you think really in 2017, we still need to be pursuing this
Are you there?
concept of a functioning valve in the deep venous system?
Well, so those are 2 or 3 questions. Where do you want me to go?
Well, talk to me first about what your thoughts are thinking back on your pioneering work when you were doing valvuloplasties. What patients do you think perhaps really had superinguinal disease that wasn't appreciated at the time because none of us were thinking about it at the time?
Well, we were doing venography all the way, so I know what was above the
agree.
inguinal ligament. And so when they had disease above the inguinal ligament in the post-thrombotic, we approached that either simultaneously or primarily fixing the obstructive outflow first.
Okay, and then you went to taking care of the insufficiency if symptoms persisted.
Yeah, and so some of those were iliofemoral, and so we would repair with a combined procedure, clean out the system above and put a stent in above. We were standing in the 90s, and at least to establish an outflow above, and then work on the valve below. Does that answer you?
Yeah, no, I think it does. So Fletcher, you're up. Now that we seem to be relatively convinced that we do need to find something, what do you think are some of the challenges that face the inventor or industry when they're trying to consider, developing a system or a valve that's going to work in the deep venous system? Just give me a few, and then we'll go to some others.
Sure. I think from the industry perspective, there's a lot of different obstacles. Some of them are technical and clinical, and others have to do with sort of fundraising and market uncertainty. But I'll focus on the technical clinical for now. I think the biggest issue is a lack of a really good venous model. This is a very difficult problem to solve. As you can see, many people have been trying to do this for a long time, and we can iterate in our lab and develop different ideas, but to really test them, animal models, the animal vein is far too compliant to really mimic adult human veins, specifically diseased human veins. And cadaveric tissue is hard to come by and also has its own shortcomings. And so our team has really had to work to answer a lot of different types of questions and different types of experiments, but never really getting the full picture until you get into an actual clinical trial, which we have been able to do, but took 6.5 years. And so one of the big hurdles is being able to raise enough money to get a trial to the point where you can have confidence to submit to ethics committees and whatnot and get into an actual clinical case on usually the most desperate patients without really having a great model to test different iterations leading up to it. So that's been the #1 challenge for us.
All right, Mark Glickman, talk to me a little bit about some of the inherent anatomic issues regarding developing, a deep venous valve in terms of the vein size, in terms of location of placement, and how you approached with the veno valve, trying to figure out what may be the way to get around these anatomic issues.
Well, I think one of the biggest issues is patient selection, Steve, because you want enough flow through the femoral vein and more axial flow through the femoral vein than through the collaterals. because with any type of model, if you don't have enough flow through the femoral vein, then any type of device you're going to put in probably will fail. So I guess patient selection, making certain that the femoral vein is of adequate size. We're working with a 10 millimeter, 8 to 10 millimeter diameter, the need for it. I've gone down the surgical intervention route as opposed to the percutaneous. Just being a student of history, knowing that most things start with surgical intervention and then migrate to the endovascular. So, one is having adequate flow within the femoral vein or popliteal vein. That's going to be very important. And then second is vein size and characteristics of the vein is also going to be secondary, very important. A sclerotic obstructive vein is not going to be helpful for any type of surgical intervention for valve replacement.
Yeah, so Nikos, let me ask you a little bit more about determining and how you feel we can determine, location of placement of valves from an anatomic viewpoint. What are the things we can use to help as to what's the best place to put a valve in a particular patient?
I think if you look at the natural locations of the valve, typically about 3 valves, as Dr. Kistner showed us and other cadaveric studies. One is proximal, one mid, and one distal. Hemodynamically, it makes more sense to put the valve in the distal place. To evaluate the vein, you can do with regular ultrasound now because the imaging is great. But if you want, for the beginning, to enhance the imaging, to use venography or better IVUS. So now I think we have the imaging modalities to determine the size of the vein, the post-thrombotic damage, and if I had to bet where to put the first valve, if one valve is enough, it will be on the lower third of the vein. And I made this discussion with Dr. Kistner a long time ago, and he told me the same.
Okay, then you both must be right. Franz, where are you thinking is going to be the best way to evaluate where to place the valve? And then if you had your druthers, where do you think the best place anatomically is to put it?
Excuse me about the question. So the location in the iliac vein, or do you mean the superficial popliteal?
You can say wherever you want, but say you have a system that's insufficient from external iliac down to the popliteal. First of all, what are you going to use as your way of sizing what size you're going to put in, and where do you think is the most ideal place to put it?
Yeah, sizing is a big issue for me,
right.
Because should we oversize in about 20%, and how do we measure it? I think Nikos has already mentioned it. How long has the patient to stand up and then examine the diameter of the vein to be treated? I think at the moment I'm aiming at a post-thrombotic syndrome where there is recanalization of the superficial femoral vein, and those veins are not that much changing in diameter as veins that have never been through a thrombotic process. So the valve has to be able to deal with this. In my experience, when we had patient selection with no valve, so that was a very rare pathology. In those cases, it was not unusual that we oversized a little bit more because that vein didn't went through a thrombosis. But I think the population is too small to go only for this very selective group of patients. So my aim at the moment is patients with a post-thrombotic syndrome and a percutaneous technology to bring in a flow regulator. Because I worked with the valves. We did the live case, as you know, from Jobst Medical Center. It was broadcasted at the meeting in Phoenix from the late Ted Dietrich. But we left that direction and went into a flow regulating concept.
All right, so I want to get some, if we can, semi-consensus here for our listeners and readers as to if everything is equal, and I know that's hard to say, where is the best place to put a functioning valve. So Fedor, can you, let's try and be specific, and even if we're wrong, let's see if we can come to some consensus. So we're talking common femoral, proximal femoral vein, mid-femoral vein, distal femoral vein, or popliteal?
Well, let me start with a comment. First of all, when we talk about reflux as the cause of the disease, we're talking below common femoral vein, because the veins above that rarely have valves. So we're really talking about two systems. One is the axial reflux through the femoral vein, popliteal vein into the calf. The other one is the axial reflux also through the profunda to popliteal to the calf. So depends on the circumstances. If the profunda is competent, femoral vein will be the place to put the valve. If the profunda is incompetent and the femoral vein is incompetent, then probably popliteal vein will be the best, as Tom O'Donnell actually showed early on. So that's pretty much my take on that.
All right, Tom?
Right. Well, we decided to put it in the popliteal area because that was sort of sits over the calf muscle pump, and felt that a venous valve there would be extremely advantageous, hopefully hemodynamically. I do think that I go back to making the distinction between post-thrombotic and primary valvular incompetence, because post-thrombotic disease is totally different. It's an inflammatory disease, and if you deal with autogenous tissue, you're doomed to having this inflammatory process destroy your valve. So therefore, you have to take, as we did, new clean tissue uninvolved by the post-thrombotic process and transplant it into this popliteal area. It'll be interesting to see the artificial valves to see if they're not affected by the obvious inflammatory process that occurs in the post-thrombotic state.
Okay, Bob, just
Yeah.
give me your thoughts about, we're talking about, placing a valve in a, say, a post-thrombotic system, because that's going to be more the patients than primary insufficiency.
Well, in the post-thrombotic vein, you have to, much more complicated. You have to have adequate inflow, as one of the other speakers was talking about. And if you have partially obstructed inflow from below, probably not going to be successful. So you need adequate inflow, adequate outflow.
No, but give me a location, Bob. Where are you going to put it?
Okay, well, so that makes a big difference. So you have to analyze the femoral. Well, first of all, the common femoral vein. I have no experience, and I don't know of any successful experience with placing a valve at the common femoral or above. Where we have always put the valves has been in the femoral vein, down to the popliteal vein, or an interposed valve at the profunda vein. So if you have leakage in both the profunda and the femoral vein, then the popliteal vein as the only place to put a single valve, or if you're going to put a double valve in some way, you could put it in the profunda and the femoral vein. The level in the femoral vein, I don't think makes any difference whether it's at the upper end or at the adductor canal.
All right, good. No, and I tend to agree with you. I mean, my time spent with the Harry, we started putting them lower and lower down and wound up in the proximal popliteal vein as well. And I tend to agree with that.
Yeah.
Is there, I mean, so when you're creating this, Mark, where are you planning on having the veno valve being placed? Somewhere in the femoral vein?
Yeah, in the proximal femoral vein or in the popliteal vein, depending on the type of reflux. As Dr. Kistner said, if they have deep a profunda valve insufficiency, you're going to need one in the popliteal vein to really accommodate these patients.
Yeah. All right, so let's go to the actual construction of the valve itself. In terms of some of the valves are monocuspid, some are bicuspid. And, you know, we always try and recreate nature when we're thinking of making something prosthetic, but maybe that's not always the best way of doing it. So I want to talk a little about the positive and negatives, if at all, but what is the reason why some of the valves are monocusp and some of them are bicuspid. Anybody here want to take Franz? You have any thoughts about bicuspid versus a monocusp valve?
Yeah, and an experience as well. When I joined Venpro with the PVVBs, that was a percutaneous venous valve bioprosthesis, a tricusp. We use tricusp to accommodate all the changes in diameter. When it occurs, the valve is still competent. I think that most of us know the concept. It was later used for the TAVIs. When I joined Venpro, there was a big experience already going on with a monocusp. And that one was actually difficult to implant in the femoral vein, so it was very often used in the common femoral vein. But having said so, I was looking for another concept and came up with the idea of a flow regulator, a kind of spinnaker shape, so that really relaxes when you're in a horizontal position, and as soon as you are in vertical position, the sail catches the wind and the flow catches the flow regulator. And so that's a different concept, but it avoids any problem of thrombosis inside the cusps at the long-term follow-up. So that was the whole idea behind the development of a sail valve. I still try to avoid the word valve because it isn't a valve, it's actually a flow regulator.
Oh, so Franz, are you saying that we should not have you on this call because we're talking about deep venous valves?
Yeah, sure, because you have to think a little bit out of the box if you're working for it for over 15 years, well, almost 20 years now, then you realize that valves in the artificial valves in the venous system, that those valves are always having their shortcomings, specifically when you are in a horizontal position and your venous flow is going up and down as a pendula. And for that reason, during the night or during the day when you take your rest, that flow system has to be totally able to adapt the physiological conditions of the forward and backward flow in the vein on the respiratory rhythm. And that is the reason that my philosophy at the moment is not focusing on a specific valve concept, but on something that can be best compared with a sailboat.
All right.
Catch the wind and then let to go.
Yeah, let me ask you, so Fletcher, your blue leaf device has a way of creating both a monocuspid and a bicuspid. But what is your preference, do you think, when you're doing this?
So the goal of the procedure for us is to limit flow in the backwards direction. And I think our procedure allows for sort of in situ decision-making based on that vein. And so the physician would create a monocuspid valve and then check for competency. If it seems that there's still too much leak going through, the physician can then form another leaflet on the other side, creating a bicuspid valve. And so for us, we've found that smaller veins, a monocuspid valve tends to do most of the trick, whereas on bigger veins, bicuspid valves seem to be better. And so for us, it's really a clinical risk-benefit assessment of the bicuspid valves are a little bit more damage to the vein wall. Monocuspid is less, but potentially a little bit less flow restricting. And the other important thing that is we keep in mind is for us, no one valve necessarily, the goal isn't to be 100% competent, but because of the mechanism for creating these valves endovenously, we can place potential leaflets in valves at multiple levels. And so it's really a more customizable procedure based on the flow patterns, based on where collaterals are coming in, and based on the healthiness of the vein wall. that the decision is made as you go.
All right, good. Now, Mark, you have for the veno valve, it's really a monocusp valve.
That's correct.
And
Sorry.
talk
I
to
just
us a little bit about that.
Dr. Maletti, when he did his procedure, it was a monocusp. And I think we don't need to have perfection here. We need to have improvement. And if you can reduce the reflux and prevent a lot of regurgitation, you're going to get improvement in your patient's symptoms. So you don't need to be 100% great. You just have to be 80% great to get good results. And so we've seen with our hemodynamic models that we have very limited reflux with our monocusp. We have a little less tissue than a bicuspid venue, and I believe that in a monocusp we can provide marked improvement to patients without going through a more complicated issues with a bicuspid leaflet.
So, Fedor, I mean, you've discussed this. You've studied the valve and stuff in the human. What are your thoughts about a monocusp or a flow regulator versus something that exactly mimics the human valve in terms of what we're trying to accomplish?
Well, and I agree with pretty much everybody is saying that some degree of help can be provided by monocusp valve or sail valve, and it's much easier to do. The real questions, though, are different. Is how much of the improvement it will get, and more importantly, the longevity of this, how long it's going to function. And there is a whole body of studies, evidence that the bicuspid valve provides the optimal flow in the veins. That's obviously evolutionary development in the low velocity, low shear rate flow. This is more optimal than tricuspid or monocuspid structures. There are also some studies, particularly the Sanka subgroup, show that mechanical forces, the load on the leaflets itself, is optimized in bicuspid configuration, not in any other tricuspid node. So some degree of improvement can be provided by monocusp structures. The question remains, would that be enough, and how long it's going to function?
Steve, can I make a comment?
Sure.
I think it's interesting when you have, quote, the ideal valve, that a human valve taken from somewhere else in the body and then put it in the popliteal vein and see how it alters hemodynamics. And we had the opportunity in our vein valve transplant series to look at APG values in these patients post-op and then at 4 years. What was interesting is that venous filling index was only normal in 1 out of 10 patients. Valve closure times, none were in the normal range, but residual volume fraction was normal in 4 out of 10. Despite this, patients healed their ulcers over a 5-year period, and only 2 had recurrences. So basically what I'm saying is I agree with people, you only have to improve it a little bit, because even putting in a bicuspid valve does not make the hemodynamics as we know them normal.
Yeah, and I agree. And we've all have spoken about this hypertensive threshold, this certain level that you just need to get the venous pressure below to get improvement in healing and or symptoms. And you don't have to be perfect, and everybody has said that in the venous system. Nikos, I want to ask you a little bit. Have you ever studied the flow patterns in either monocusp situations versus bicuspid by ultrasound? And if not, that's okay. But what do you think? Does it really matter from a flow viewpoint, whether it's bicuspid or monocuspid? And do you have any ultrasound documentation that?
Sure, I think hemodynamically and evolutionary, the bicuspid obviously is more secure because it prevents almost any leakage. Thing is now, the reality is I went to see Dr. Maletti operating, and I saw quite a few of his patients, and then I discussed with him several times, particularly last year, his results. He told me that the monocusp does a job, but the fact of the matter is that 5 years later in his series, over 50% of the monocaps valves are going to fail. And which valve is going to fail or not from the get-go is not known. But 50% are going to fail in 5 years.
Yeah, and I think that's been our problem with valves. They tend to work initially, but then even the axillary valve transplants, somebody was going to jump in. I'm sorry, who did I cut off?
Is Glickman. It was that I still think the quality of life for these patients, patient satisfaction for 5 years, is certainly better than what the alternative is for many of these patients. And
Yeah.
at the end of the day, patients we want improvement in their quality of life, and that's really has to be very important when we evaluate. Not only are we looking at APGs and everything else, but we have to be looking at QOL and how people are responding to therapies.
Yeah, no, I think
if you use the measure that other people have used in Maletic, it's called, ulcer-free days. Making the valve is significantly improves this, and that I think is very important to the patient.
That's
put it in historical perspective. We actually initiated that term when we reported our valve transplants report many years ago, and it is the most important thing, as Dr. Glickman said. It tracks quality of life.
Right, and again, that's what we're all talking about when we're managing vein disease in general. It's not limb salvage; it really is quality of life, no matter what interventions we're doing on vein patients. I want to switch a little bit some of the ideas that we've been talking about. I want to talk a little bit about the concept of an open insertion versus a percutaneous insertion, and what are the positive and negatives of each. So there's technologies out there now that involve some open and some percutaneous. So let's see, Bob Kistner.
Sure.
Talk to me a little bit about open insertion versus the percutaneous insertion, and does it matter?
Well, I have to be talking to you about things that I don't know anything about.
Well, that's usually the best way. That's usually the best way to talk about things.
Well, I can be.
Then you're not biased by anything.
Well, I think there's great precision to an open procedure, but it is an open procedure, and I don't think I think it would carry some additional risk of thrombosis, perhaps. But I'm not sure that that's really true. It might be the same, and probably the effect is how well you can seat the valve, whatever dimension you have, how technically perfect you can seat the valve and have it remain in the place where you want it, where it gives ideal function. But to me, if we're going to have a valve that we can put in through a catheter and put it in various places, that would be the ideal if it would work. So I think that the percutaneous, if it's nearly equivalent, would be the way to pursue it.
So Franz, thank you, Bob. So Franz, let me ask you here. A lot of the Venco valve was percutaneous, and the problem with it was never delivery of the valve. It was really thrombosis or that developed later on or some other issue. I mean, but do we think that the percutaneous way was a negative thing, and had that valve or other valves been put in open, that it may have been more advantageous?
You mean about the Venpro valve?
Yeah.
Because with the Venpro valve, also during the live case, we went through the jugular vein and positioned it in the iliac vein, the external iliac vein. That functioned well, but is a very cumbersome procedure. And the whole problem of that venous valve, which was of biomaterial, was that actually the trial never was finished because the investors wanted to go immediately into the direction of a implantable valve in the heart. And so the tricusp was used as an ideal model to accommodate the different diameters which is of course easy to understand because you have a monocusp and a bicusp. That mono and bicusp are more difficult to accommodate the central flow closure and opening, and then you still have a high chance of late thrombosis. And having said so, I thought that the percutaneous technology, where you can go from below just the distal popliteal and then implant your valves where you think they are functioning best, so either in the distal external iliac, in the common femoral, in the superficial femoral, just below the profunda femoral, it's easy to place such a flow regulator. So I left the concept of purely mimicking valves as they are in human bodies. And I think that if you can regulate the mainstream of the flow, that is sufficient to lower the backflow. And specifically at rest, when you are in a horizontal position, there should be free floating leaflets, call it leaflets or sails, in the lumen. And as soon as you change your position from horizontal to vertical, it catches the flow and allows, when you walk, the pump function, and then the flow goes at the wall side and not in the midstream, up back to the main body. And that is how I left the concept of the valves.
All right, Mark. Mark, talk to me a little bit about open insertion and what are some of the positives about open insertion?
Well, I think that the major issues with percutaneous is, can you get the right size and make certain the valve opens up? So I'm going with a surgical approach first, so that I can make certain that I have good quality vein, number one. Number two, that I'm controlling the size of the vein so that I know my valve will have, my vein, my monocusp will have a nice wall to oppose to. So I have direct inspection. I have security and placement of the valve. I know it's not going to be angled. It's not going to be 20 degrees off, 10 degrees off, 5 degrees off. I can control it, just like Dr. Kistner said. Once we have proof of concept in man that it works, then someone can take it to percutaneous. But we don't have proof of concept. And I think that's really going to be imperative to do it surgically, just like we did aortic aneurysm repairs before EVARs came on, thoracic aneurysm before TVARs, carotids before carotid stenting, that we need to go this approach and then take it somewhere else.
All right, Tom, you have any thoughts about open versus percutaneous?
No, I think Mark said it well. If you can't be comfortable with a percutaneous approach, then it may just be the approach that dooms it from being functional, whereas you know all factors of control with an open, and therefore you are proving the concept. So I totally agree with what Mark said.
So Fletcher, just to give you your say here, yeah. I mean, obviously you are creating, the proof of concept's kind of been done already with the Mileti valve in an open viewpoint, and now you're creating a similar type of valve in a percutaneous viewpoint. Do you have any ideas? You think you are better served percutaneously than open as Mileti's doing it?
Yeah, I think obviously technical complexity goes up. I think the advent of IVUS is a key tool for us for selecting the right vein segment and in general, patient selection. But I think the two non-obvious reasons percutaneous is important outside of morbidity and being able to maybe treat less severe patients would be the ability to treat in multiple locations in the same procedure and multiple orientations as well. And then another one, elephant in the room, would be sort of, interventional radiology is a really growing field in this. A lot of those docs are stenting patients a lot, and I think being able to include that group in addition to vascular surgery is really important in terms of, now hopefully no one on this call starts throwing tomatoes at me for saying that, but I think in the future of venous disease, it'll be important because there's a lot of different types of physicians treating venous patients now. So those are two non-obvious reasons percutaneous is important. But the technical hurdle is certainly higher than when you're in there with your bare hands and able to get a more precise procedure done. So
you've kind of segued into one of the other things, and I see Fedor is kind of semi-smirking there as to who should be doing this. And is our goal to, as you already hinted, Fletcher, to make it percutaneous so more people can do this? And is that the right goal? And is that going to be a good byproduct, or a bad byproduct? Or should it be really a select group of individuals at first, and then release it on the masses? Fedor, give me some of these thoughts.
Well,
and you could try to be politically correct. That's okay.
Well, it's hard to be politically correct with this kind of questions. I think initially, definitely, that should be a selected group of people who have a deep understanding of the pathology and who are capable of capturing the right things during their initial experience. Having said that, then you look at the next step and the next generation, and the easier is procedure, the more people you can train appropriately, the better we serve the patient population. Now, let me use that to just bring one more issue that was not touched upon when you discuss open procedures. You just kind of made the general statement that it is more invasive. But you know, all of you who operated on post-thrombotic veins know that sometimes it's not easy at all, even in the femoral segment. It's really sometimes a struggle, and the time in OR and the cost. And the other thing is, it's unclear what the results of the manipulation with the vessel at that conditions are. And again, coming back to your question, I truly believe that at least in the first step, it should be a very selected group of people who use that device or devices.
Yeah. All right. Bob Kistner?
Well,
do we limit this to surgeons, or can we unleash it into the interventional population, whether it's cardiologists or radiologists?
Well, you know, I think what Fedor was saying, when you have when you deal with these veins, first of all, your preoperative, if you're going to open them up, your preoperative impression is right about 80 to 90% of the time, and wrong about 10 to 20% of the time. You find pathology that you didn't find before, and if you're at an open procedure, you can often find a way around that. Whereas I don't know what you could do with a percutaneous procedure. But I have real concerns about having people be able to just drop a valve in the veins without a lot of knowledge about the natural history of the problem and what the thrombosis might do. These post-thrombotic veins, they are not simple, and they have all kinds of problems up and down the vein that weigh into the flow characteristics and the longevity of any valve that we put in. So my concern is, if you make it too easy, it's going to be malused, it's going to be overused and abused and improperly placed.
Yeah. Nikos, just as Bob was talking, what percentage of people is it primary insufficiency versus post-thrombotic that are going to have, enough disease that or enough either ulcers or significant symptoms that are going to need these valves placed? Can you give us any idea about?
Yeah, I'll tell you, at least in the patients I've seen over the years, by far, I'm talking about over 95% plus are post-thrombotic limbs.
Right, that's correct.
The primary sufficiency on the deep veins is a very rare thing.
Right,
particularly when you remove all the superficial veins.
Yeah. No, and I think that points out what we're saying. These are not the slam dunk, easy, pristine veins that have not had post-thrombotic changes that you're going to just shove a valve into. These are the more difficult veins to get access to, the more difficult veins to work on, whether it's open or closed. So it's not for the person who just has good catheter skills. It's really for the person who understands the complete pathology and how you manage the entire patient, and just don't put a valve in. And I'm glad to see all of us are shaking our heads, yes, yes, and yes. That's not to put down other people, but it's really to say that the initial people putting this in are those who have really thought about the underlying problems and pathology with the patients. So we're kind of getting down to the end here in time. I'd like to. Anybody want to bring up something that hasn't been brought up? And feel free. It's okay.
I would like to just say that having a valve in the deep system that works could be a paradigm shift of how we approach these patients. Although we've talked about doing the ablations, etc. If we do have a valve that functions, that does well, etc., it could be a paradigm shift in the treatment modalities. And we've talked about this before, that we treat it with ablations and foam and etc. But if we have something that really treats a disease, it could be changing for the way we approach these patients.
All right, and that, I mean, do the other guys agree with that? Obviously, people who are develop valves may be thinking that, but let's ask some of us. I mean, do we think this is going to be like the first or second thing you go to versus the fifth or sixth thing you go to if you have a durable, functioning valve?
I can give you a different approach.
Go, Bob.
I grew up in veins by trying to construct deep veins, and we did a lot of that for a long time. And people kept telling me, well, you don't have to do that much if you just fix the surface veins. In maturity, I found out that they're right, that if you fix the surface veins, the majority of the people are adequately served. I don't think we know the true natural history of deep vein reflux, but many people tolerate it for many years, and yet it may be the source of recurrent disease and ultimate failure of the system in the later years of life. So I think we have so much to learn that it's rather dangerous to go dropping valves in too many veins.
I would echo that, Bob.
Wait, let Tom go first, and then Nico.
I would echo that. What we found, we did a lot of deep venous reconstruction, nothing like Bob, but certainly in the 30 to 50 range. And all of a sudden, when we started to be aggressive with SEPs and with superficial disease treatment, the need for treating patients with venous ulcers with deep venous reflux dropped dramatically in our vein center. But now the patients who have failed superficial treatment come around, and they're the candidates who will require deep venous reconstruction, which I think is the next great frontier for venous surgery, if not vascular surgery.
Yeah, I mean, we've been working on this for God knows how long to try and find something good for the deep venous system. Nico, you wanted to say something? I'm sorry.
Sorry, Nico.
Nico, you're muted by some reason.
That's unusual.
Yeah. We can talk about it because he can't hear us.
As a moderator, I'd love to have that ability.
Right. Nico, you are muted. Unmute yourself. Oh, thank you. He's not looking.
No, he's
shall we just ignore him and just go on? I feel bad.
Yeah.
He's still talking. All right. So anyhow, anything else for anybody? Because I mean, to me,
could I ask?
Yeah.
Could I ask?
You go, Bob, and then
Fletcher. Fletcher, have you been able to work at what size valve can you do either a good monocuspid or bicuspid valve? What size vein?
Our device
is it appropriate
right now,
for the popliteal?
It is, depending on the size. So right now our device's sweet spot is 7 to 11 millimeters. And so that's one device fits those ranges, and we have different knobs you can tweak on the device to cater. And so we go in and do an IVUS read for a given segment to get a perimeter check and use that to decide exactly what vein size, valve size. So 7 to 11 is our sweet spot. In the future, we might have to make a big and a small version as well.
Yeah, but I think...
So the smallest size is 7 millimeter?
Yes.
Okay, thanks.
Yeah, and what do you call it? Mark, yours is what, 8 to 10?
8 to 10, yes, sir.
Yeah, and Franz, what size are you looking at?
Yeah, the under size is 8, and you can go up whatever size you wish, 15, 16, 18, whatever. But what I missed a little bit is the pathology you want to treat. And I don't mean the general pathology, but in specific the condition of the venous wall. And that is something that you have to overcome because with the patients with the most severe condition of the venous wall, we try to avoid to treat those patients either by operation or by a percutaneous placement of a flow regulator. And that is what we have to focus on because then that's the largest population and the group. If we find something that can be used also in this very horrible conditions of the venous wall itself and still having a functioning flow regulation mechanism, then that's the huge patient population that we are looking for.
Yeah. Is there anybody that thinks once one of these valves or techniques or whatever are done that the patient would not need anticoagulation? Is there anyone thinks that these patients do not need lifelong anticoagulation after?
For how long, Steve?
I said,
the question is for how long?
No, I said, do you think they need lifelong or do you think they do not need lifelong?
Well,
sorry, but guys, I think that the DOAC time is now here, and we should go for the new drugs. And in 2 or 3 years, it will not only 10A, but also factor 8 and factor 12 are in the current pipeline of the pharmaceutical companies, and those drugs are anticoagulants and in a low dose with a very low risk and ideal for the venous development, for the venous technology development.
Yeah, I mean, go ahead, Tom.
These patients inherently are at a risk for recurrence of DVT, so they should be on some form of anticoagulant, irrespective if you're low dose if you're doing an operation. Certainly. Yeah. I agree.
I fully agree. But what I'd say is the direct oral anticoagulants are now the way to go, and it's not the traditional way of going and taking your tests, your blood test, etc.
Oh yeah, we even use it in the United States, Franz.
Yeah, no, we have it here now. No, but also.
But you have a big trial, the Voyager trial, running in the States.
I know, we're kidding you. But what I'm saying is you also don't want to make these people worse. I mean, the worst thing is if you put in a valve and then it thromboses and they may get worse, as opposed to putting in a valve that then becomes, incompetent and doesn't function. So in my mind, I can't see how anybody's going to get away without keeping these patients on some form of lifelong anticoagulation, which is absolutely fine because it's certainly becoming safer and safer to use. I mean, that's my feeling, unless anyone thinks differently.
I would only say for our specific case, if the valve isn't an implant but is from natural tissues and there is no foreign body indwelling structure, once you get past an initial sort of healing phase or reendothelialization, the thought is maybe lifetime anticoagulation would not be necessary, but that needs to be shown in clinical trials.
Right. I think if it's working with anticoagulation, to be hard pressed to stop the anticoagulation if they're tolerating it without a problem.
But Steve, some of the patients are with the primary disease. You're talking about postural body disease, to which I absolutely agree. But when it comes to the primary disease, that's a different story.
Right. But as Nico pointed out, that's a very low percentage.
Yeah, it is low percent.
That we're going to see. And primary disease, I mean, Bob, I don't know what you think. That may be a better one for a valvoplasty rather than putting in a foreign body, personally.
No, to the contrary. I think.
Really?
I think that we may find when we really understand primary disease that later in life, treatment and in the more severe cases, to be able to implant a valve in the femoral popliteal system might be very useful. I think that's where the change may come.
All right, good. Anybody, anything else? Okay, otherwise, I mean, I think we've begun to scratch the surface. We're in a very exciting time. We have a significant number of technologies available coming out, hopefully, that are going to, one or two or all three or whatever, is going to work, and we'll have choices for our patients. But thank you all for your thoughts, and we're done.
Thank you, Steve.
Thank you,
Thanks,
Steve.
everybody.
Thank you very much. Yeah, thank you.
Thanks.
Bye, guys.
Good
Bye-bye.
job. Good job.
Bye.
Good job. Thank you.
Bye. Thank you.